welcome. I'm Professor Adam Thompson, and in this discussion, we're going to talk about bradycardias in treating the bradycardic patient. When it comes to treating the bradycardic patient, it's going to be much like any other dysrhythmia in the sense that we're going to follow recommended guidelines for the most part. We're going to follow what the American Heart Association puts out based on best practices and best evidence. Sometimes, the algorithm doesn't necessarily fit the patient because, not all of our patients tend to read the textbooks, and the body can do different things, and there's different pathophysiologies out there. So for the most part, you can follow this stepwise fashion, these algorithms, and treat patients. But of course, there are going to be things that are outside the norm or outside the box. So if we go down this algorithm, you're going to notice the first thing is to assess the appropriateness for the patient's clinical condition. And the heart rate will typically be less than 50 beats per minute when you have to treat them. Now that consider everything, the patient, their presentation, and realize that there are some patients that have a resting heart rate less than 50. The world leading jump rope, world record breaker is going to be walking around with a heart rate in the 50s or below 50s. Your marathon runners are going to have typically lower heart rate than anyone else. So again, assess for the appropriateness for their clinical condition. All right. Next, you're going to want to make sure you're taking care of oxygenation and ventilation because hypoxia is one of the main causes of a bradycardic patient, especially pediatrics. They tend to become bradycardic very early on and with hypoxia, where your adults, when they have severe hypoxia, their heart rate tends to drop. So make sure they're being oxygenated and ventilated. And don't forget to give fluids. There's something called the Bainbridge reflex. And the Bainbridge reflex is pretty much if you increase filling on the right side of the heart. So if you give them IV fluids and it goes into the right atrium, that right atrium is going to have these stretch receptors in there. And those stretch receptors tell the body to pick up the heart rate. So the sinoatrial node will then be stimulated via those stretch receptors. So if they tend to be having a sinus rhythm, giving them fluids may be an effective way to increase their heart rate. Of course, a lot of our bradycardias, they have AV blocks or ventricular rhythms or something like that. So fluids may not be as effective, but it's still a good treatment either way. Of course, you're going to want to get a 12-lead ECG if available, and you don't want to delay therapy to get that 12-lead ECG. Typically with these bradycardic patients, just like with your tachycardic patients, you're going to want to be doing simultaneous assessments and treatments. So hopefully you have a well-established team that you can delegate these tasks to, have somebody starting an IV while you're placing them on the 12-lead, so on and so forth. And then you're going to want to see, is this patient symptomatic? Are they having symptoms indicative of poor perfusion? All right. And this list is the same list that they use in the tachycardia guideline or algorithm. Do they have hypotension? Is their blood pressure low? Do they have an acutely altered mental status? That's a big one. If they have an altered mental status due to bradycardia and hypoperfusion, that's a bad sign. That's pretty ominous. Signs of shock, this would be your pale, cool, diaphoretic patient. And if they're pale, cool, diaphoretic and bradycardic, that's bad, right? Because typically when somebody becomes hypoperfused, their heart rate wants to pick up to compensate, but the inability to compensate may be, a more serious condition. Ischemic chest discomfort. So this isn't like palpitations or, just a mild discomfort. This is your squeezing, tightness, chest pain. This isn't a little bit of sharp chest pain from a cough. This is your ischemic chest pain, right? And then acute heart failure. This could be, witnessed via pulmonary edema, acute onset pulmonary edema, something like that. If not, if they don't have any of these symptoms, then of course you're going to just provide supportive care. You're going to monitor and you're going to observe, because we don't treat asymptomatic bradycardia. We just treat the symptomatic bradycardias. So let's say we do need to go down to treatment. Now, one of the things that may be a little bit controversial, because it wasn't always this way, but it currently is that the AHA recommends with all bradycardias, you go ahead and administer atropine first if they're symptomatic. The reason this is controversial is because we know that a lot of our high-grade AV blocks and our idioventricular rhythms or our ventricular escape rhythms, they're not going to typically respond too well to atropine because the vagus nerve doesn't really innervate the ventricles to the same degree it does the atria. The vagus nerve is what atropine works on, And by blocking vagal tone, you're going to kind of passively increase the heart rate. You're taking the brakes off. So the idea is to give 0.5 milligrams of atropine pretty quickly. You don't want to give atropine too slow or in too low of a dose, because that will cause them to have a rebound or a reflex bradycardia. It can cause the bradycardia to become even worse. So give that pretty quickly, and then if that is effective, you could repeat it. If let's say you give them atropine, their heart rate increases, but then after several minutes the heart rate begins to decrease again, you can give another round of it up to a total of 3 milligrams every 3 to 5 minutes. So you don't want to do that and reach that maximum dose if the atropine is ineffective. If you give that first dose of atropine, that 0.5 milligrams, then and it doesn't do anything, then move on. The only time you would continue every 3 to 5 minutes up to 3 milligrams is if it actually did something the first time. So if you give 0.5 milligrams of atropine and it doesn't do anything, move on. And what do you move on to? One of these three things: either transcutaneous pacing, dopamine, or epinephrine. They all have their benefits, and they all have their downfalls. For instance, transcutaneous pacing is an elite skill. Not a lot of people are actually very good at transcutaneous pacing, and I'm going to provide some of those pro tips for clinicians in this video. And even if a lot of people that don't realize that they're not very good at transcutaneous pacing aren't very good, because it's difficult to actually identify electrical capture, and many people think that they have electrical capture and reinforce that belief with this false mechanical capture that they may feel due to the actual electrical stimulation of the muscles, and it's not really doing their patients any good. So we're going to talk about that a little bit. Dopamine. Dopamine is great for your cardiogenic shock patient. It's not a super positive chronotrope, so you're not going to get a lot of rate increase with dopamine, but it is good if, let's say, the patient's experiencing myocardial infarction, and maybe they have some pulmonary edema, some, like a right ventricular infarct, and you don't want to increase the infarct with epinephrine, because it could be dangerous in the presence of an infarct or ACS, then dopamine may be a good choice. But for the most part, you're going to want to skip dopamine and go with epinephrine with your bradycardias, because epinephrine has a really good positive chronotrope effect, and it's going to increase the heart rate pretty dramatically. And that's going to be via infusion. Both dopamine and epinephrine are going to be given via infusion, and the doses are over here. You have dopamine is going to be 2 to 20 micrograms per kilogram per minute. It's a weight-based infusion. And then epinephrine is 2 to 10 micrograms per minute. It's not weight-based. And then, of course, if none of that works, you're going to want to get on the horn and consider talking to a physician or a cardiologist and get some expert consultation. And this patient may be a candidate for transvenous pacing. So as promised, I'm going to discuss some tips when it comes to transcutaneous pacing, because this skill is effective for a lot of bradycardic patients, but we're not executing it well as a whole, as clinicians in all levels. We're just not executing it well. And a lot of it is lack of education and lack of training on this skill. One of the biggest problems is those rhythm generators that currently exist. Whether you're training in ACLS or paramedic school or med school, the rhythm generators that you can set to capture at a certain milliamperage when somebody's practicing, they don't give you the false capture that you see in real life. And if you're wondering what I'm talking about, I'm going to show you here in a few slides. But first, let's talk about pad placement when it comes to transcutaneous pacing, because this is huge. Remember, you're not providing nearly as much energy as you do when you provide synchronized cardioversion or manual defibrillation. But we use the same type of pads. But we want to move those pads so we're kind of skewering the heart in a much closer proximity. So the way that we've identified that we should be putting these pads on the patient is what we call anterior-posterior placement. So on the anterior side, we want to find the apex of the heart, and that's where you want to put that anterior pad over there. So if you find the sternum, make sure you stay on that sternal border with the edge of your pad, okay? And then you're kind of going to go right about where you would place V3, the V3 electrode on a 12 lead. So you're going to go left of the sternum on the patient's left, and you're going to stay above the xiphoid, kind of right over where the apex of the heart would be. Okay, and then on the patient's back, on their left side again, make sure you stay on the left side. We're going to mirror, that anterior placement on the back, and we're going to stay on the left of the spinal border. So on the front, left of the sternal border; on the back, left of the spinal border. And if you see this this cross-section view here, you can see where these pads end up. All right, so here's our sternum there. Let me change colors again. Here's our sternum right there, and here's our spine right here. And if you stay on that, this is where you feel the process on the back. So if you stay on the border of that and place your pad there and anteriorly here, you skewer that heart, so to speak. You sandwich it right in between those two pads, providing the best placement for getting that electrical capture. And I know you're wondering why the apex of the heart. Well, because this is going to be a ventricular capture, ventricular pacer once we, finally get it placed and get started. So it's called anterior posterior placement. So let's take a look at a case here, and hopefully by doing this and by reviewing these different tips and tricks when it comes to pacing, we can make pacing great again, so to speak, and get providers, more knowledgeable in the skill and using the skill more effectively. So here we have a symptomatic bradycardic patient. We're not going to get too much into their presentation. Just trust me that they're symptomatic, and they are in fact bradycardic, rates in the low 40s. So we've already administered atropine, and now we're going to start pacing here. And I want you to take a look, and we've started our attempt at pacing. We have a low milliamperage setting at this point. Let's say it's about 30 milliamps. So we're about 30 milliamps on this top strip. And we notice that our monitor right away will start providing us with these spikes. That's telling you where it's trying to pace. Okay? And we see after each spike this big QRS looking thing, right? So after each one of these spikes, you see this big wave. So ask yourself, now when you first look at this, be honest, do you think that that is electrical capture? Because a lot of people do. When they see that, they think they're seeing electrical capture, and you could kind of understand why, right? You have a spike right where it should be before a QRS. All right, so you say this is a QRS, and then you have what might be a T wave here, right? But that's not electrical capture. That's what we call pseudo capture or false capture. And that's just an artifact that's provided due to the electricity that the monitor is putting out. Unfortunately, that will not give you a pulse. But when you go to palpate, a carotid pulse on this patient, you might feel, because if you look at them, if you physically look at this patient, they're going to be twitching with each one of those pacing beats. It's going to be rhythmic at the same rate that you set because they're being electrocuted, so to speak. Their muscles are being stimulated. So they're going to have, or they may have, what feels like a pulse and what looks like electrical capture. And unfortunately, none of this is improving their condition. There's a couple ways I know this is not electrical capture. For one, right here, the underlying rhythm, okay, it's continuing throughout. And that's fine that it continues because we could have a demand mode or something like that on our pacer. But what couldn't possibly occur is this very first one that I circled, okay? Let me go back here and label this. Number 1, okay? That QRS complex is right on top in the middle of that T wave, okay? And the absolute refractory period isn't even over yet, and we're having the intrinsic or underlying rhythm occur right there. So that couldn't happen if this capture beat was in fact depolarizing the ventricles. The ventricles would still be in a refractory mode where they wouldn't be willing to accept an outside beat or an ectopic beat or another beat, okay? And you see it happen here again, and here it's more on the relative end of the refractory period, but still, if that was a true capture, you wouldn't see these beats occur throughout. And also, what you're looking for with capture is a nice big wide QRS, okay, and it could look very similar to this one we see here, and then a big T wave in the opposite direction, bigger than what we're seeing. Okay, so let's continue this case because we're going to continue to increase those milliamps. So let's say we're at 45 milliamps now here on the top. even 55 or 60, and now we're starting to see some differences here. If you look at this beat, so I'm going to label them, all right? This first one we'll call beat 1, then 2, 3, 4, 5, 6, all right, 7, and then 8. All right, do any of those beats look like electrical capture? Because if you ask me, I'm going to say a couple of them do. We have partial capture here. Beats 1 and 3 and 5 look very different than what we've seen so far. Now we're seeing what looks like T waves following each one of those pace beats, which tells me that we're having repolarization. And you can't have depolarization without repolarization. So now that we finally see T waves, we're pretty got a good feeling that those are good capture beats. And we see still some of those other beats that weren't capture beats, and we can confirm that again with beat number 7. We have the underlying QRS complex, or the underlying rhythm, occur right where the absolute refractory period would be, which can't happen physiologically unless you have two hearts, right? All right, so that couldn't possibly happen. So we still have only partial capture here. So let's say, with that we were up to almost 60 milliamps. So we keep going up. And I want you to remember that number 60 milliamps, because it's going to be very uncommon that you get full electrical capture before 60 milliamps. So be rather quickly as you increase your voltage to get to 60 milliamps while you're watching, and then slowly increase following that. And now that we have partial capture, we are going to slowly increase until we capture more beats. And let's say this is about 80 milliamps right here. And now what do you see? Well, every one of those beats looks uniformed. It's wide. We have a T wave following each beat. And this looks like full electrical capture. We no longer have the intrinsic rhythm, occurring on this absolute refractory period anymore. So we have a good feeling that we have full electrical capture here, and this patient will likely improve. And of course, one of the other tools that I'd like you to use is capnography. If you have capnography on this patient, and of course you're getting blood pressures, but you can see, just like when you get ROSC on a patient you're working in cardiac arrest, you get a sudden increase in that capnography as their circulation improves and as some of that carbon dioxide that has built up makes it to the lungs. When you improve somebody's perfusion that was in such a decreased perfusion state, they can also get a nice rise or spike. It's not going to be a spike to the degree you see with a ROSC patient, but it could be a relatively significant increase in their capnography value. Using that, and also utilizing the pulse oximetry pleth wave, okay, if you're getting a good pleth, for instance, if we were looking, let me clear all this out of here. If we were looking at this rhythm across the top, and we were watching the monitor, and we had a good pleth wave, what it would look like is you would get the pulse ox pleth here, and then not here, and then here, and then not here, and then here, because the pleth wave is very much reliant on an actual pulse. So this would confirm a mechanical pulse with the electrical capture. All right, and then as you got down here to this bottom one, okay, then your pleth wave would be more consistently matching the rate of the monitor, because we have full electrical capture and hopefully full mechanical capture, providing us with a very consistent pulse. In addition to that, our end-tidal CO2 or capnography value would increase, okay? And that would give you a good indication that you have capture, your transcutaneous pacing is effective, and your patient's overall condition is improving. Let's take a look at another case as we attempt to make pacing great again. All right. So in this case, we're starting out. We've already administered atropine. It's a very bradycardic patient, very slow rhythm, and we're trying to pace now. Let's say we're at about 20 milliamps here. And do you see capture? Do you see any electrical capture on this EKG? And hopefully by now you're saying no, you don't see anything. You see a spike followed by pseudo capture, and there's no T wave. And you can't have depolarization without repolarization. So if there's no T wave following that, you certainly don't see any capture. You may say that this could be capture, and that is possible. Okay, these beats that look a little bit different, that is possible that that's a little bit of a T wave, but it certainly wouldn't be full capture, and we wouldn't have a very good heart rate with that. So moving on, this is what we end up with, and this should look very similar, this top strip, to what we saw with the first case when we didn't have electrical capture. So we're just seeing this pseudo capture, this false capture as some call it, and each beat looks the same and it looks rhythmic, but there is no, if we were looking at our pulse ox would look like this, all right? If we were looking at our capnography, it would stay decreased, and these are not T waves. This is just part of that pseudo capture pattern that hopefully you become familiar with. Our T wave should be much bigger than this, okay? Should be much bigger than this. And if we go ahead and we take a look at the underlying rhythm, we're going to note this patient is now in asystole and full cardiac arrest. So this patient did not fare well. This case actually did go much longer than what I've shown you here, where we had this top strip and they thought they had full capture with this top strip here, until they identified that their patient's condition was getting worse, their blood pressure was going down, until they couldn't actually get any blood pressures and the patient lost responsiveness. They felt for a pulse, they realized there was no pulse, they identified asystole and started working this patient as a cardiac arrest. So we've seen the first case where we eventually did get full electrical capture. The second case where the patient actually, did not fare too well from the lack of recognition that they didn't have capture. And now let's take a look at another case. We have a bradycardic patient. This is how their initial rhythm presented. They did not respond to atropine or fluids. They were oxygenating okay and all of that. So we move on and we're attempting pacing. And remember, you can do these things in conjunction. So while you're attempting pacing, you can have your partner prepare an epinephrine infusion or prepare a dopamine infusion and be ready to administer one of those if pacing does not work. All right. So let's take a look. And what do we see here? Well, a couple things I want you to note is that these three beats you see here, that's just the underlying rhythm. Okay, that's the underlying rhythm. So if you take those out of the equation, you'll see that you just see that pseudo capture, right? You see the spike, you see what looks like a QRS, but there's no T wave, all right? And you can't have depolarization without repolarization, so we don't have capture here. All right, so of course we increase the milliamperage, and let's say we're now up to about 55 milliamps with this top strip, and still we're not seeing much in the way of capture. There is a little bit of, this one beat right here, that's kind of promising. But other than that, we're just seeing that pseudo pattern that we're now used to. It's very wavy, right? You notice how this, it looks like it could be a T wave. It kind of just fits this nice smooth wave, right? That's not capture. That's not capture. This right here, that's something that's just part of the underlying rhythm, which has now gotten worse. It looks like it's much slower. So we're going to keep increasing our milliamps. Let's say we're up to about 70 milliamps here, and now we're starting to see something. I do see, again, this looks very promising. That is a capture beat. We have a single capture beat on this bottom strip, so we know it's possible. We're only at 70 milliamps. We finally have a capture beat. We need to increase our dosage to get better capture. So here's that last rhythm again. That was at 70 milliamps. So now we increase and we make it up to, let's say, 90 milliamps. And that's what we have. All right. And I'm just coming up with numbers. This could be at 120 milliamps. Who cares what it takes? If your patient is conscious, and compass menace and all of that, of course you're going to want to give them some sedation. Consider some ketamine or some Versed or Valium, whatever you have available. Depending on how much of it they can manage due to their condition, you don't necessarily want to give them a whole lot of respiratory depression before fixing their perfusion status. So if they become conscious while you're pacing them and they are obviously in pain, start treating them then. So what do we notice here? Now that we've increased milliamperage, we see a very good difference between the bottom and the top strip here. Now we have, this is obviously full capture, right? Spike, big wide QRS, T wave in the opposite direction. Everything looks how it should. We finally have full electrical capture. So hopefully you're taking home these main points and don't get confused by that pseudo capture. And again, use your tools. So with this bottom one here, we would have, you know, a pulse ox pleth. If as long as you weren't having a lot of movement, you get a nice clean pulse ox pleth. That might look something like this. You know, you might get something like that. Not a whole lot, right? Because the pulse oximetry is based off of the pulse, so they need good mechanical capture. So then finally, when you get down here, you get a nice pulse ox pleth that matches, you know, their actual heart rate that you're providing, and you would also be analyzing and assessing your end-tidal CO2, your capnography, and see if you get an increase in that, see if their blood pressure improves, and of course use, you know, actually put your hands on the patient, feel for a distal pulse, see if they have a nice pulse that matches the monitor, and then you are practicing, you know, this skill at a much higher level. And it is a skill that requires a lot of education and a lot of training. And, you know, I'm going to put out a lot of different cases following this video to hopefully, again, make pacing great again. It really is a skill that it can be useful for a lot of patients. We're just not executing it well as an industry. You know, as clinicians out there, we're not doing a good job. So we need to be educating each other and constantly improving and refining this skill. Thank you.